はい、田村先生。田村先生、あれ、でもミュートになってるからかな。誰だろう。誰か。
田村先生、聞こえます？
お時間取れれば、これてます。
OK です。ありがとうございます。じゃあ大丈夫。
OK で共有してもらってで OK。はい、OK です。
じゃあ、時間になりましたので。Okay, then let's start. So, today, Zaki-san will have a presentation for us. So, please start.
So today I would like to share with you my study. It's an syllabus. Can we make this as a full size? No. Can you go few? This my doctor. Okay.
レーザーポイントができたわ。
OK.
ハウスのポイントあげる。
So I have the way. Okay.
OK.
So I will I will share with you my study. It's in silico study titled as Simultaneous integrated post for pancreatic tumor using passive delivery and carbon ion therapy. So, and the content of my study will be as following. First, I will share clinical background, then physics background, then I will introduce SIB and share with you the methodology, result, discussion, and then conclude. So to start with, pancreatic cancer remains one of the most challenging malignancy. The World Health Organization show that it has high mortality rate and relatively poor survival rate. Globally, there are approximately 511,000 cases and more than 467,000 deaths. In Japan, the number is increasing twice faster than globally. There are 45,000 cases and 40,000 deaths by 2024. So this means that those numbers show the need to find more effective treatment for pancreatic cancer. Pancreatic cancer is challenging because of the prognosis, poor prognosis, and pancreatic tumor are frequently hypoxic, which means it can reduce the effectiveness of low LET. And there are other reasons, many other reasons, such as the pancreas location. It is surrounded by highly radiosensitive organs, like the stomach, the duodenum, small and large intestine. In addition to the bowel movement and the gas movement, which they can change the density day by day. Also, the need to control the LET distribution in the gross tumor volume. And carbon ion is a great option because the Bragg peak can provide sharp dose localization. Carbon ion has LET, high LET, and the biological effectiveness is high and it is less dependent on oxygen. Now the physics behind it is very well known that when carbon ion particles are traveling through its path, they slow down, the velocity decrease, and the stopping power and LET increase. The highest LET is generally located near the end of the particle range, and because more ions stop at the distal region of the Bragg peak, it will become denser, and we will have high LET. This high LET can cause double-strand break damage, complex DNA damage. However, the clinical carbon ion beam is not monoenergetic. The energy, it contains a spectrum of energy from the spread out Bragg peak, which means at any point, LET is not only one value, it's actually distributed of many value from different particles. So for that reason, to make the biological dose uniform, we have to deliver non-uniform physical dose and RBE. because the biological dose depends on the RPE and the physical dose. Therefore, we use dose averaged LET, which is the contribution of LET in a single volume. The important point is that LET weight the dose of each LET particle in a single volume. Therefore, with carbon ion, we can control where the high LET is distributed and where it can be deposited. So, despite the high potential of carbon ion therapy, the conventional uniform dose approach challenge has many limitations. One of this limitation that the dose escalation is very restricted by the proximity of the sensitive organ nearby, like the stomach, spinal cord, duodenum, and the organ motion, the range uncertainty, which affects both dose and LET. In addition to the distribution of high or low LET inside the GTV. In contrast, SIB, simultaneous integrated boost, can overcome this limitation by dividing the target according to risk. Higher dose can be delivered to the high risk target volume. Lower dose can be delivered to the lower risk target volume simultaneously. And the hypothesis of this study is that SIB can increase dose and dose average LET in the high risk target volume while reducing the unnecessarily dose to the lower risk target volume to maintain protection of OAR. And the objective is to investigate the impact of SIB in dose distribution and dose average LET distribution using carbon ion passive delivery system at Gunma Heavy Ion Medical Center. SIB means that SIB means different dose are delivered to different target subvolume within the same treatment fraction. A higher dose per fraction will be prescribed to the higher risk subvolume, and a lower dose per fraction simultaneously delivered to the surrounding lower risk target. And if we compare the SIB with the conventional uniform dose approach, we can achieve a better dose escalation in a shorter time, better OAR sparing, and better biological effectiveness. Also, we can have a better dose average LET distribution on the GTV because the SIB allow the concentration of high dose and high LET in the tumor core while maintain safe dose level in surrounding tissue. And it might help also with the resistance against the organ motion and setups uncertainty. In 2015, Inanuma Sensei and his college developed a modified microdismetric kinetic model which support the clinical RPE to be used for carbon ion. And in 2017, the feasibility of SIB dose escalation were demonstrated by Kawashiro Sensei. And in 2020, Hagawara Sensei set the threshold of LET, the dose average LET, showing that for pancreatic cancer, there is no reoccurrence when LET higher than 44 micrometers. And then 3 years later, Nakaji Sensei showed that SIB can increase dose and LET in the gross tumor volume. And last year, Shinoto Sensei demonstrated that SIB is safe to be used for pancreatic cancer up to 67.2 gray. Nevertheless, all the previous study have focused on active beam delivery, with no research yet conducted in passive beam delivery. So this is a study and Gunma Heavy Iron Medical Center. It's a mono-institutional retrospective study. The study included 8 patients with an inoperable pancreatic cancer receiving daily CT. All patients received dose prescribed as 55.2 per 12th fraction. For countering, using contrast-enhanced CT merged with the 4D CT. The GTV, CTV1, CTV2, BTV1, and BTV2 were defined as the main target, and the main OIRs were stomach, duodenum, and intestine. So treatment plan were generated by using XUN. Dose and structure information were exported and analyzed using Python and MIM to determine and evaluate both dose volume histogram and LAT volume histogram. Also, we looked at the dose average LAT profile. For the dose parameters, they were dose 2cc and D95 and D50s. Equivalently for the LAT, where we looked at the LTCC, L95, L50. 2 SIB plan were generated, M7T1 and M7T2. The difference between these 2 plans, one of the beam has slightly different angle. When the result become reasonable and feasible, we then looked at the patient's plan to see the difference between the conventional plan and the SIB plan. The conventional plan deliver uniform dose. Where is it? The conventional plan deliver uniform dose prescribed across all the target. For the SIB, the plan deliver more or higher dose to the higher risk region. So, for example, in the conventional plan, we have 55.2 gray will be uniformly distributed along the GTV, whilst in the SIB plan, we will boost the dose from 55.2 to higher dose in the GTV. At the same time, we will reduce the dose delivered to the lower risk or the OARs. So the SIB technique involved the irradiation of all target volume during the entire treatment period, different dose level being delivered simultaneously in different target volume, leading to different dose average LAT distribution. And to generate these plans, we have to go through few steps. First step is to define the priority levels. So the first priority was to cover the GTV and high risk target volume with high dose. And the second priority is to cover the low risk BTV with lower dose. Then we prioritize protecting OAR. After defining the priority, step 2 is to optimize the beam intensity by changing the weighted dose of each beam. And the goal was to create dose gradient between the high risk target volume and to the low risk target volume. Also, we want to make sure we have the dose to fall off at the OAR boundaries. And then the step 3 is the beam by beam summation, which means each beam geometry and angle were optimized independently. And the accumulation of all the dose from each beam will create the desired dose and dose average LAT distribution. Because LAT fluctuates along the path, LAT increase as carbon ions slow down, but velocity decrease. So the maximum LAT occurs just before the stop in Bragg peak region. Therefore, the contribution of each beam is adjusted to deliver the same LAT distribution. at every fractions. So all targets will be irradiated during every fraction, but they will receive different, where is this? But they will receive different LET distribution. The GTV, the gross tumor volume, and the high risk region, they will receive high LET more than any other region, whereas the lower risk region and the OAR will receive more of the low LET or the medium LET. And then by this way, the combined LET from each beam will be accumulated fractions by fraction. By the time we reach fraction 12, the total accumulated dose is higher than the boosted volume in the lower and lower in the nearby volume. And SIB influence both the physical dose and the biological dose. Therefore, dose and dose average LET must be evaluated separately. Also, at the same time, because changing the weight dose of each beam can change the distribution of dose average LET, we've evaluated whether this redistribution increase the dose or LET. So we looked at conventional way and the SIB way and different posted plan. For example, SIB 10% posted weighted dose, 15%, 20%, and 30%. To look for the right balance where we improve the LET and dose in target and limited the toxicity of OAR. So the result, it's a dose volume. This is a result dose volume histogram of two plan, M7T1 and M7T2. The difference between the two plan was slightly changing one of the beam angles. And we can see that there is the GTV-based dose volume histogram and the BTV-based dose volume histogram and SIB-based dose volume histogram. And in the dose volume histogram, there was no significant change between those two plans. However, when we looked at the LET volume histograms, there is noticeable change and between this team angle arrangement plan. The OARs show they are more sensitive in the SIB plan than others. So the change in angle can change OAR easily. Then we look at different parameters to see the dose average LET distribution. So we looked at the L95, L50, and LTCC in each target for each plan, and then we try to find out the difference between the SIB and the GTV and SIB and the BTV plan. So when we look in each target, we can see that SIB plan always sit in between both the GTV and the BTV. GTV is the farthest one and the BTV is closer. However, SIB and GTV and CTV and in OAR, this and 1 and 2 were in the middle. And this confirmed that SIB can increase dose average LET in GTV and can shift the LET distribution without producing extra harm to OAR. Then when we look at each individual target, we can see that at the GTV, the SIB improved the L95 and L50 and L2CC compared with the BTV has improved. And this is indicate that SIB can increase LET distribution in both the lower end of the GTV and in the center of the GTV. Then when we look at the CTV, SIB has improved all the L95, L50, and LTCC, but they are not uniformly crossing the CTV, which means that the biological redistribution is not uniform across the whole CTV. because the CTV is larger. Then when we look at OAR, the SIB proved the LTCC was lower than the BTV plan and the SIB and the GTV plan. And for the OAR2, SIB value were generally intermediate. And so this result are encouraging because increasing dose average LAT and GTV did not show any huge increase in OAR. However, looking at LAT alone is not sufficient. We must also consider the dose received by the OAR. M72 plan has agreed and show the same result as M71, but I'm not going to share it here for the sake of time. I would like to move to a clinical data for the patient one. And by looking at this dose volume histogram for patient one, we can see the conventional one, the SIB one. The target was GTV, CTV, C1, CTV2, BTV1, BTV2. And for OAR was the stomach, duodenum, and intestines. We, in the conventional plan, most of the targets were below 60. Then in the SIB plan, the dose were increased to above 60, shifted all the way to the right, while maintaining OAR without large change. So that shows that in the SIB plan, the target structure are shifted through higher dose, while OAR remain and only show a small change. And the higher ISO dose were more concentrated in the GTV within the tumor in the SIB plan. Now, when we look at the dose distributed in each target to look at the D95 and D50, we saw that the most increase occurred in the GTV for both the D95 and D50, and there are small increase in the BTV, which means that the passive delivery SIB plan successfully produced a controlled dose gradient rather than just simply increase the entire target uniformly. And when we look at the dose distribution in OAR, also we see there is in the stomach, it has increased by 2.91 gray. In the duodenum, a small increase, and the intestines, D2CC, were 1.80. And this showed that the largest change occurred in the stomach. So target dose escalation was achieved, but it was not without the slightly increase of the stomach. Also, we look at the LAT volume histogram. And then in the LAT volume histogram, we have the SIB plan and the conventional plan. The BTV1 was, in the conventional plan, was receiving the most of the high LAT, is the furthest one. But in the SIB plan, the BTV was shifted to the left. All the other target volume has received higher LAT. The GTV one was the furthest here. So while maintaining small difference in OAR. So the SIB plan produced a visible rightward shift in the GTV, CTV1, CTV2, and BTV. However, the shift is not identical for every target. This indicates that higher dose average LAT were exposed to other volume. And for the OAR, the general curve shape remained similar, although there are small difference, but still similar. Now, we also look at the LAT volume histogram for different weighted dose, and increasing the weighted dose from 10 to 30 show us that GTV is shifting to higher value, which means it covers higher dose average LAT. However, also the response is not completely the same for each target in here. Because this result depends on the individual beam range and which field contribute most to the strong lesion culture for the structure. So when we look at the distribution of LAT in the target volume, each target volume, the GTV, CTV1, CTV2, and this, we analyze both the L95 and L50, and we can see that in L95, it increased progressively with the weight from 10 to 30, and then similar behavior where in the L50, it increased progressively. Also, both CTV1 and BTV1 were improved while modifying the dose, but the most acute noticeable result was the increase in the GTV, L95. Then when we looked at the distribution of LAT, those average LAT in the OAR, for the stomach and for the other duodenum and intestines, we see that the 20% weighted dose plan appear to provide the better overall treatment for patient number 1. It increased the L95 and provide higher GTV. It also slightly reduced the duodenum and the intestine from the other plans. However, there is a slightly increase. The only disadvantage is the slightly increase in the stomach. Discussion, SIB increased dose coverage in all evaluated target structure. The SIB effect was produced by manually changing beam weighted dose. In the SIB plan, the largest increase of D95 and D50 were shown in GTV. Increasing the beam weighting progressively increased L95 and L50 and GTV. The SIB 20% plan achieved L95 more than 44.86 kV per micrometer in GTV with limited dose average distribution in OAR. Dose of OAR increased slightly, critically in the stomach. Dose average LAT was more sensitive to beam geometry than dose volume histogram. And according to patient 1 result, SIB plan should be generated with patient-specific case. Study limitation, it is a very small it has very small number of patients. And it is in silico study, which means it evaluates the treatment plan, not clinically. And daily ball, motion, and gas and setup error were not fully considered. And the L95, L50, and L2CC describe the distribution of dose average LAT. They are not directly representing the minimum LAT or any clinical outcome. For future direction, SIB can be used with for LAT optimization.